Okay, good morning, everyone. And thank you for joining us this morning. So this is the return of Discussions in Diagnosis. We took a several-month hiatus, partly for the summer and partly we were trying to realign our speakers for the fall. So this morning, it's my privilege to welcome Paul Epner. Paul Epner and I are friends. We probably met about 15 years ago back in Chicago when he was just getting started with the Society to Improve Diagnosis in Medicine. But Paul is now currently the vice chair of the board of directors of the Sepsis Alliance, which is the topic of our discussion today. As some of you may know, that September is National Sepsis Month. We had a Sepsis Awareness Day, I think, just last week or so. So we're going to talk a little bit broadly about sepsis. And Paul's background is very interesting, I think. He's not a physician. He has a business degree from University of Chicago, which I think Paul is still the best in the world as programs. At least that's what they tell me. And he has a very lengthy career at Abbott Labs, partly in the diagnostic space as well. So welcome, Paul. Thanks for joining us this morning.
Glad to be here.
So there's been a lot that has come out in the news lately about sepsis and its burden, but can you give us a bit of a summary of how serious and how widespread this problem is?
Sure. First, thanks for joining up again with me. We've worked together on a couple research efforts, so it's great to be doing this collaboration now today. Yeah, it is a very timely question. About a year ago, Congress asked AHRQ, the Agency for Healthcare Research and Quality, to do a burden study on sepsis. And it was published, the report to Congress was published last week. So we have really up-to-date data, and it was a very broad look at the burden. And in it, you'll see things like the number of in-hospital stays rising in the last 5 years from 1.8 million to 2.5 million in 2021, which is a huge increase. And for the majority of those stays, sepsis was the primary reason for the stay as opposed to a secondary reason or anything like that. Mortality is 350,000, and that's probably understated, only because you don't see very many death certificates where sepsis is the cause of death. And so depending on the counting methodologies, et cetera, it may be much higher than that. And the statement is that it contributes to 1/3 of all hospital deaths. It's involved in 1/3 of all hospital deaths. There are more than 6,000 children that die annually from sepsis, and there are more than 15,000 amputations each year because of sepsis. The cost is over $60 billion to the US economy, much of it to Medicare, over half of it to Medicare, because it clearly does affect aged more than others. But it's a huge cost, the number one cost line, presumably in hospitals. Readmissions are very high, and both readmissions from inpatient stays, readmissions following discharge from the emergency room, but in both cases, readmissions are high. And we're learning more and more about the long-term effects of sepsis. It appears that more than 50% of sepsis survivors have something that we all call post-sepsis syndrome, which can be cognitive impairments, emotional, physical. There's just so many different ways it affects people and over long periods of time that we're still just learning so much more about. There's certainly disparate impacts based on age, of course, but sex. Males are much higher, have much higher rates of inpatient stays. Race is much higher mortality with Blacks and also other minorities compared to whites. And the location of residence is very important, where socially vulnerable communities have much higher rates of costs and stays and mortality compared to more affluent areas. So it's really with this nature of those statistics, you wonder why there isn't a war on sepsis, but there isn't.
Wow, that's fascinating. I can attest personally to signing death certificates and not being sure about sepsis and putting down respiratory failure as the primary cause, and then the other, heart failure or whatever. So sepsis is certainly underdiagnosed. Just getting back to that point, why do you think there's a geographic disparity? Is it just access to care, or what do you think's going
Um,
on?
it's probably multiple things. No problem is simple. If it was simple, we might be able to do something about it. So it certainly is access, and access being transportation, access being comfort and trust in the systems too. There in certain populations, there's less trust. There's fear among patients. There's costs that they're afraid of, lack of insurance, things like that. Getting back to the access, but also understanding. Sepsis can sometimes sneak up on you very quickly, as you know. And because of that, you may think you've got flu, just quit complaining, stay home, and just you're fine. And I think that can be more prevalent in communities where they can't afford to miss work, or they can't afford to miss childcare, or they can't, where other kinds of issues are occurring like that as well.
Okay, so that kind of brings us to our second question. You touched upon that a little bit, and that is the extremely high morbidity and mortality. What do you think is driving that overall?
Well, I think it's a number of things. So first thing, let's all be clear. This can move very quickly. I'll give you two quick stories, and they're both personal. I have Crohn's disease. I was in the hospital decades ago getting hyperalimentation when we didn't know what to do about fistulas that didn't close. And so I was on day 10 of my hyperalimentation, and went to bed at 10 o'clock at night feeling great. And by 2 in the morning, I was up screaming in pain. And they used a Swan-Ganz catheter and later told me that my blood pressure was 20/5. I don't know if that's accurate or not, but that's what I was told, and that they couldn't get any reading with traditional blood pressure cuffs or anything like that. I ended up having 3 more weeks in the hospital and having a kidney shut down, having to have a cut down and go on dialysis. So, I mean, I went from feeling great at 10 o'clock to 2 o'clock, doctors calling my family and telling them he's not going to survive the night. My second story, my dad had 2 weeks of flu and finally went to his primary care doctor, who said, "You look terrible, go to the emergency room." Got to the emergency room at 2 in the afternoon. They made him wait in the emergency room for about 2 hours before they decided to put him in a room at 4 o'clock, a general room. By 6 o'clock, he was stumbling and they moved him to ICU. I talked to the doctor at 7, and he said, I said, "Do I need to rush down there? What's his white count?" With things like that. The ICU head said, "He's fine, leave him alone. He needs some rest." And 2 hours later, he was dead. So these are things that when mortality can happen so quickly in an interval, that alone is one of the reasons why mortality is so high. And then the question, I think, also gets to diagnosis. Diagnosis, we don't start with as you know, and we've had this conversation before, we don't start with an outcome. We don't start with sepsis. We start with symptoms. And those symptoms, especially in the case of sepsis, can be very nonspecific, and they can have many different, the signs and symptoms of sepsis can also be true of many other things. And you don't know which person's going to move on to severe sepsis or septic shock all that quickly. I think that in many cases, sepsis isn't on the differential. And if it's not on the I mean, it should be on so many differentials. And it's not just sort of, if I talk about the differential, like there's a piece of paper and we're checking a
Right.
box, and that's not what's happening. But if you think about what are the three most likely and the three can't miss, sepsis certainly should be on a can't miss
Mhm.
in someone's mind. And I think too often it's not. And because of that, we don't institute the protocols that could really be life-saving. The second thing is that there's controversy about antimicrobial resistance in many people's minds, and they're somewhat resistant. So let me back up a second and say, sepsis largely comes from the community. More than 80% of sepsis cases that result in hospital stays come through the emergency room. It's present on admission. And so you're dealing with an emergency room that's busy, that's seeing lots of different kinds of cases, that has short time to make assessments. And just saying, is this an infection or infection related is sometimes, not sometimes, often a judgment call.
Right.
People think there's always going to be a temperature. There isn't. You can have patients with sepsis have zero temperature increment. Yes, low blood. I mean, there's some obvious signs, but there are certainly other signs. So I'm probably giving you too long an answer, but let me just say that not getting it on the differential, worry about, do I use a broad spectrum antibiotic when I'm worried about antimicrobial resistance? And by the way, giving a single dose to buy time, there's no evidence that it increases antimicrobial resistance.
Right. So getting back to that one point you made about the differential. So someone comes into the emergency room, eventually diagnosed with sepsis. What conditions is it often confused with, or what?
Well, it's first thing, it's a complication of
Right.
infection.
Right.
So what is confused with is, and we've seen so many cases, you're familiar with Rory Staunton's case and others, where you're told you do have an infection, but it's flu, it's stomach flu, it's something, you get sent home. Altered mental status is a significant indicator of sepsis. And altered mental status can be thyroid, it can be depression, it can be Alzheimer's, it can be so many other things. So that the non-specific nature of the symptoms is certainly something that can take people in many different directions.
All right. Well, thank you, Paul. And thanks for sharing that personal story about you and your father as well. So getting now to the big question, what can we do about it? Not initiating treatment necessarily, not those details, but on a system level, what do you think what direction should
Well,
we go in?
one of the, CDC very recently in the last year has come out with their core elements on sepsis. So if you're not familiar with that, there's a assessment tool, there's a report card, there's 7, let's see, I have the list right by me. The major core elements talk about hospital leadership, commitment, accountability, multi-professional expertise. There's actions, tracking, reporting, and education. So there are components, there's videos online, there's tools online, everything there's something available very much there. I think certainly making it a priority within your institution. In the ARC reports, we see state-to-state variation. And certainly among some of the statistics shared, Ohio has a relatively high burden compared to many of the other states around it. In other ways, it's doing well, but that state-to-state variation is very much present. So I think we really do need to just make it a priority. Second, focusing it, because we can't solve every problem in every department. It's an ER problem. Unless you want to go upstream of there to EMS or even to nursing homes or other kinds of clinics doing in service for physicians that are in primary care, things, and because there's a awareness impact, right? If you never see it or don't, well, you all see it at the hospital, but if you don't think about it often enough, it's not going to be in that differential. So actually trying to do that. There's the SEP1 protocol that we actually is going to be part of value-based care starting in 2026. And implementing that consistently, having a high compliance to SEP1 has been shown to reduce mortality. And then I think just collecting data is to try to better understand your local situation. What is your length of stays? What are your costs? How many, what's your readmission rate? What's happening in that post-discharge period, especially surgical wounds and things like that that can become infected. What kind of proactivity are you doing there? So first, I think you got to do the Pareto to understand what are the biggest sources of your preventable opportunities, and then come up with, like any quality improvement initiative, focus on their tools are out there.
Right. So I think we're fortunate in our system, thanks to Dr. Goldstein, who's on the call today, and Dr. Macias on the pediatric end, that we do have a high level of awareness, and we are investigating sepsis trigger tools in general. But is there something, Paul, we can learn from some other place, some other country or jurisdiction that's had some success in tackling this?
At an individual institution level, I'm not as familiar. I know that Steve Simpson, who's our board chair and who used to be the president of CHEST and is on the Surviving Sepsis Guideline Writing Committee and stuff. He has instituted in Kansas a strict compliance with SEP1 and has shown remarkable results in terms of driving down the rate of the mortality associated with sepsis. So there are other things. There are Haley Prescott in Michigan has done some tremendous work up there too in the VA system, and they have made it the Blue Cross Blue Shield has funded a data collection effort in Michigan that has had tremendous success. So there are things, and I can try to pull, or you can do your own lit search and come up with some quality improvement initiatives. But other countries have made sepsis a priority and created a national sepsis action plan. And those countries, the UK in particular, have done some great things with getting their rates down.
Great. That's good to hear about. So let's talk about your organization, the Sepsis Alliance, and what its mission is, whether it's patient facing or clinician facing. Can you tell us a little bit about it?
Sure. It's about a 15-year-old or a little more organization that was founded by an endodontist who lost his daughter, her 24-year-old daughter, after an outpatient hemorrhoidectomy. He had never heard of the word sepsis and just said what happened to him, what happened, and then decided to do something about it. So it started out really about building awareness, and its vision is a world in which nobody is harmed by sepsis. Its mission is to save lives, reduce suffering by educating the public and professions, and by being committed to preventing and curing sepsis through partnerships, alliances between them. We have something, so there's a significant patient component, but there's also a significant physician component, and you can register at Sepsis Institute, which is found at the sepsis.org. There is a separate page, but you can get there from sepsis.org. The Sepsis Institute is designed for physicians. There are over 100 free educational programs, many of them giving nursing credits, or in some cases CMEs for physician education. There's just next week, there is the Sepsis Alliance Summit, which is 3 days of short courses designed for physicians, free registration, all virtual, I noticed David Bates was going to be speaking. So they have some very, speakers that I'm aware of, many others over the course of 3 days. And there's the Sepsis Institute not only has downloadable educational programs, they have resources, toolkits, and peer-to-peer networking, blogs, and things like that people can contribute to. So there are a lot of things that Sepsis Alliance can do at no cost and hopefully bring a lot of value.
Yeah, that's terrific. Lots going on. So let's close out maybe talking about Sepsis Awareness Month and how that came about and what kinds of things are happening and what the goal is really.
Sure. Well, as we said, so much of this is awareness, because we think that's what slows down things. We have a mnemonic that's not that great, but it's our attempt to, like stroke, etc., create. I don't know if you can see this time, which is temp and infection and mental decision decline and extremely ill. It's an attempt. But so we're trying to build awareness for things like that. We work to get states to declare National Sepsis Day within each state. And over 30 states have done that each year. We had a Hill Day last week, which I participated in, and visited with various legislators and talking about it. And we have actual legislation that has been introduced in the House that is attempts to do two big things. One, seek funding for 5 state-level data repositories modeled after cancer registries. These would be sepsis registries. And all we're asking Congress for is to fund 5 states, up to 5 states, to start to play around in collecting and making registry data. Because just like we know today that cancer is really more than 400 different diseases, we know sepsis is more than one disease. And we think it's going to take things like registries to really come up with the phenotypes and things to really understand that, which will drive improved treatments and improved care. And it also will mandate this legislation that we come up with our own national strategic plan for sepsis.
Oh, so that's really terrific. And as you probably know already, one of our demonstration projects within our ARC-funded Diagnostic Center of Excellence is about sepsis, which Dr. Goldstein leads with Dr. Macias as well. So thank you so much, Paul. We just have a few minutes left. I'm going to turn it over to our audience here and see if they have any questions.
Hey, Paul, it's Jessica.
Hi, Jessica.
Thanks for coming back to Cleveland and giving us a talk. Appreciate it. Yeah, so I agree. One of the challenges that we're starting to look into is really that readmission portion. We spent a lot of time on the front end in the emergency department, really standardizing our teams and our response to sepsis. We're starting to, we actually have a core team of people looking at the inpatient sepsis mortality and why we have the increased mortality once sepsis is diagnosed outside of the emergency department. So we have a team that's working on that, and we're working with our Epic leads to make sure that we are firing appropriately. We're in that phase where we just we have a new Epic system. It's been about a year. And so we're really trying to optimize the BPAs so that we're not over alerting. We're in that space right now where we're getting some alarm fatigue. So we're trying to really dial it back so that we're triggering it appropriately. But one of the challenges that we just don't have a lot of experience with is that post-discharge population and what we can do to try and prevent those readmissions. What does partnering with SNFs look like? Because it's so broad, the reasons why people are coming back, it's not necessarily the same infection. It could be something else. So have you had any success in partnering with some of the area nursing homes, or, what does the optimal discharge paperwork look like to try and get people attuned to when to bring your loved one back to the hospital, or connecting them to their primary care physician, et cetera?
So it's a great question. It's one that I think is still in early discovery around the country. Post-discharge instructions. So I read something on it just last week, and now, of course, that I don't remember too much about the details, but we think this is an opportunity, a real opportunity. And in fact, there is a move afoot to create an ICD-10 code for post-sepsis syndrome that may help bring more information and attention to the area that ultimately leads to readmissions. I do think that in what I vaguely remember about what I read is that the instructions to patients about when to re-engage with the system and what to look for, whether it be things like altered mental status or other things like that, are often vague and assuring that the patient understands them before they leave, or a caregiver or a partner or is a problem and an opportunity. Additionally, I think doing educational in-service at SNFs and other kinds of rehab centers, et cetera, is an opportunity to focus on training the professionals there on what to look for and how quickly to react. So I do think there is significant opportunity there. I know there is work afoot. I will look for more of that and send you some things, and would be glad to talk further on this subject with you.
Thank you, Paul. I think if there's a general theme, it's greater awareness and education across the board. So it's wonderful that you're doing all this great work. So we are, again, very quickly out of time. Thanks for the fascinating discussion. And thanks for kicking off our rejuvenation of discussions and diagnosis. So we'll have more discussions going on month by month moving forward. And thanks to everyone for joining us this morning. Thanks to Jessica for a great question as well. And everybody have a wonderful day. Thanks again, Paul. Take care.
Thanks. Bye-bye.
Bye-bye.
Thank you. Bye.